everyone. Good evening. This is, I think I have to welcome all of you. This is a very challenging time during the evening. Maybe usually people were taking, on the way back home for dinner, but you guys are all, coming to be here. Okay, so I think it's very amazing. But this is not only just a single time. Okay, I know you have a series of classes, for this course. Okay, so today I want to walk you through one of my recent study related to the correlation between smoking and brain structure in people with schizophrenia. So first of all, I a little bit introduce myself. I am a background of a nurse and also a midwife, okay? And I have, some clinical experience, working in hospitals. And in the past about 20 years, I actually, one of my major research focus on smoking cessation. Firstly, why I would like to focus on smoking cessation, because I think this is a very important public health issue. And this is, when people can quit smoking, then maybe the people's health can be improved, and for example, the health costs can be reduced for the entire society. So that's why I've focused, my time in this area. Okay, but this time I focus on helping schizophrenia to quit smoking. People with schizophrenia. Firstly, I would like to see, is any one of you are working for people with mental health disorders? No. Okay. So have you heard about schizophrenia? Okay. So quite a lot of you, even though you are not working for people with mental health disorders, but you have heard about schizophrenia. So this is good. Okay. This project is actually a collaboration work between, among disciplines, including people from the rehab science, and also psychiatrists, and also clinical partners in Hospital Authority of Hong Kong. So the subjects are actually recruited from 3 HA hospitals. The PY, what we call the screen is. Oh, okay. Oh, all right. So this is normal, right? Okay. So including from the PY Hospital, the Castle Pete Hospital, and the Kwai Chung Hospital. And I also recruit the subjects from the community residential areas as well. So as you may quite understand, smoking might not be easy to quit, okay? But there would be possible, okay? There is something, some smoking cessation strategies are promising. But still, majority of the smokers find it very difficult to quit. Okay, so the usual quit rate in Hong Kong is, if no, healthcare professional helping, the quit rate is like less than 4% successful by the smokers themselves. Okay, so there is a lot of question why, it is so difficult to quit smoking. Okay, but we found it in particular difficult among people with mental health disorders, in particular for people with schizophrenia. A bit of background about schizophrenia. So schizophrenia is what we call severe mental disorders, okay? It actually have a lot of so-called clinical symptoms, which is very distressing. So including positive symptoms and also negative symptoms. Positive symptoms, you may heard about positive symptoms as well, including delusion and hallucination. Hallucination could be including hallucination including 5 senses. For example, hallucination in terms of seeing, in terms of hearing. Okay, for example, you know, there is no such sound, but people, you know, actually feel or heard or hear the sound. You can imagine, for example, if you enjoy a TV show or radio show, you can control to switch on and off the radio or the TV. But the sound, you know, you know, kind of, you know, hallucination affect the people like uncontrollable time. You cannot control the time. And sometimes the content of the auditory hallucination could be instructional as well. Okay, so not just, for example, instruction say bang, 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 bang. Okay, and sometimes it is like, you know, the voice could be talking to the people with the symptoms, no matter the people is doing what. For example, sometimes it's very horrible when, for example, when they are in the toilet, when they are in a private, for a private business. So that's why, you know, people with schizophrenia usually that symptoms affect their life seriously. Okay, so people with schizophrenia usually they need to take lifelong medications, okay, in order to control the symptoms. Another, you know, types of symptoms, what we call negative symptoms. Okay, negative symptoms is unlike the hallucination, like auditory or tactile hallucination. Tactile hallucination would be feeling something inside the skin. Okay, so it is like there is, you know, a small animal inside the skin, you know, moving or biting or that kind of feelings. So that would already, the positive symptoms are already very horrible. But negative symptoms is kind of more silent. Okay, it affect the people like lack of concentration. Okay, like, you know, lack of interest for any, everything. So usually, you know, people would present with very withdrawal from the daily activities and that kind. So imagine this kind of negative symptoms is not only just affect one day in a year. It is the onset of the schizophrenia usually start from, for example, early 20 or end of, you know, 10 something. So that's why it is like during the adolescent stage to onset this kind of problem. And then the problem might be, you know, persist. Okay, so that's why, you know, usually should the lifetime medication is required. Okay, so but then we see there is something, you know, we need to highlight how I would like to relate smoking with schizophrenia, because firstly, you know, the life expectancy among the people with schizophrenia is decreased when compared with people, general population. But for those people who smoke, the life expectancy are even shorter. Okay, so I think you probably heard about, you know, how challenging, how harmful health hazards of smoking, cigarette smoking for the health, because they, you know, component of a cigarette stick, including, you know, carcinomic agents, and also, you know, other toxic, you know, substance as well. Okay. So, so that's why I think, you know, I'm thinking about how to, you know, control tobacco. But day back in my past, you know, more than 20 years, okay, I tried different types of, you know, smoking cessation interventions, including pharmacological intervention, for example, the nicotine replacement therapy, medication, and also psychosocial interventions. But then there is a lot of challenges for people to quit smoking, in particular among people with schizophrenia. And we observe the preference of smoking among the schizophrenia is higher than the general population. And it is even the highest among all the people with the mental health disorders as well. Okay, so this slide actually summarizes the increased, you know, possibility to acquire, you know, different types of cancer among people with, you know, taking tobacco. Okay, so there is a confirmed causative effect between smoking and some cancer types. Others, even though the causative relationship is not established, okay, but the association trend are obvious. Okay, so that's why I would like to highlight why, you know, we have to focus, you know, to find out some solutions or some explanations why, for example, why smoking cessation for people with schizophrenia is in particular difficult. Okay, so there is some background information that I won't repeat now. And I would like to, you know, highlight there is, because of that situation, in the literature, in the research, actually, you know, different people would like to focus on different areas, including to find out, you know, what would be the most effective smoking cessation interventions. Okay. But sometimes, you know, when I try out a lot, then I see there is a window, okay, and they back on, you know, why particular there are three critical questions that I would like to focus on. One is, how do smoking actually smoking intensity? Okay. In the previous literature usually focus on smoking status, smoke or not smoke. Okay. And whether what would be the difference if the people smoke for years and then finally they quit smoking. So would there be any beneficial for people quit smoking? Because some of the smokers say, okay, I already smoked for years, okay, or decades, okay. So my health is if already, you know, ruined, then it's no point to quit to quit now. Okay, so people start thinking about, you know, the beneficial effect on quitting smoking as well. Okay, but our focus is how smoking intensity. For example, the number of cigarettes smoked per day. For example, some of the smokers are actually occasional smoker. For example, less than 7 cigarettes per day, but some might take 2 packages, 40 cigarettes per day. Would there be a difference? And the duration of the smoking, would that be difference? Duration of the smoking and the duration of the illnesses. I mean, the number of years from you know, onset of the schizophrenia, would that be make a difference on the brain structure? Okay, so the second question is, does a longer illness duration of schizophrenia interact with smoking to X-ray the brain volume. Another question is the brain structural differences linked to psychiatric symptom severity. Okay, so those are the questions that we particularly would like to ask. Okay, in the literature, there's could be summarized because some people would have one explanation why people with schizophrenia would in particular difficult to quit smoking, and they are in particular more higher preference to smoke as well. So one explanation, what we call negative mechanism. So the mechanism is like, for example, the people with schizophrenia seems more vulnerable to the to smoking, because while they having the negative symptoms like lack of concentration, lack of very difficult to thinking, lack of motivation, then they would feel悶悶地. Okay, then they would light up a cigarette. Then suddenly they feel more enlightened. Okay, so they would kind of more comfortable with this type of feelings. Another negative symptoms might be sometimes people schizophrenia patient might point to have some depressive symptoms as well. Okay, they might lack of interest to everything. They look back would have some rumination due to the catastrophic behaviors that they have encountered while onset of the schizophrenia, and so they wanted to take a cigarette to calm their nerve down. Okay, so that's why just people with schizophrenia may be more vulnerable to smoking as well. Okay. Another thing is they are less able to tolerate with the nicotine withdrawal symptom as well. So some of the nicotine withdrawal symptoms, it is like people, if, for example, if they are, taking a public transport, but smoking is not allowed to, so that they might develop some what we call negative withdrawal symptoms, like agitated, unable to tolerate the feelings of missing something. Okay, so this kind of withdrawal symptoms. But some people might have physical, effect like constipation, might be, in particular wanted to eat more things, then finally would become, weight gain and that kind of things. Okay, then that's why, they would like to, get out of this withdrawal symptoms, that in return, they would have more easy to get crave for the cigarettes. Okay, so this is like the vicious cycle. Okay, this is like a vicious cycle for smoking. So in the literature, we found out there's some study actually to using the to see the brain structure related to smoking among people with mental health disorders. Okay, but we think there might be cultural specific as well. Okay, very seldom study in China has been carried out in this particular area because we see among Chinese, the preference rate between gender is very different. For example, if we look at the Western countries, the smoking rate between gender is relatively similar. But in China, in Chinese, very, vast majority of the people are men who smoke. Okay, very few. In Hong Kong, only 3 to 4% of the smokers is female, right? Another thing is globally, internationally, the smoking rate are actually slightly decreased. Okay, but in China, there is no decreasing trend, but slightly increasing trend. Okay, so the third point is, Chinese people, among Chinese, among the people with schizophrenia is very understudied. Maybe due to different influential factors, cultural factors, socio-economic factors, or other genetic factors as well. So that's why I actually, propose conduct a study. The entire study is a randomized control trial. It's a RCT. Okay. Primary purposes is to test out a new social intervention called a substance commitment therapy to help the smoker to quit smoking. Okay. But before, starting the intervention to help them to quit smoking, I would like to use the baseline data, okay, to investigate the relationship between smoking, duration of the illnesses, and so on and so forth, in related to the brain structure. Okay, so this is the outline of the study. Okay, so yeah, so of course, for this study, because we need to use MRI, the particular scale of the MRI we call structural MRI. Okay, so that means no task is related. It is required to invite the participants to do. So they just stay rest states. Okay, under the scanner, then it's okay. So the fundamental criteria, so we recruit the subjects, including, of course, they has been diagnosed of schizophrenia. Okay, but because we need to compare, the brain structure difference among people with smoking, who smoke and who do not smoke. Okay, so that's why we recruit, people with schizophrenia who smoke and also not smoke as well. Okay. Of course, we need to recruit those who are stable, under the, stable medications by the physician. Okay, so this is some outline. So apart from the MRI measure, actually we need to carefully look at the participants' history of smoking. Okay, including their years of smoking, and also one measure is called pack year. Okay, for example, the number of cigarettes consumed per day in terms of the number of years of smoking. Okay, and also other information like the schizophrenia symptoms. We're using the measure called BPRS, which is the Brief Psychiatric Rating Scale. Okay, I will introduce a little bit about that to you. Then another measure is the, the exhaled carbon monoxide, okay, which is the byproduct of smoking. And also we collect the salivary sample to test out the cotinine level as well. Cotinine is one of the byproducts of nicotine as well, okay? So the neuroimaging, we're using red states. So for the entire proposal, entire project, we also use task MRI, functional MRI as well. But for this particular questions, the data required only the West States MRI information is okay. Okay, so this measure is related to what we call nicotine dependence scale, Fagerström tests, okay, including, for example, the number of cigarettes consumed per day, and also how soon after awakening, you know, during the morning do they smoke. Usually the people, some of the people who are very addictive to smoking, they would start light up the cigarette before toilet, before mouth washing and so. So other thing is whether they can control themselves when in the during in the area which is smoking is restricted. So those are the you know, questions that we did ask, and finally we calculate the level of the nicotine dependence accordingly. Another key measure is called BPRS, that including a lot of things, okay, including anxiety, depression, for example, suicidal ideation, and symptoms of positive symptoms and also negative symptoms of schizophrenia as well, okay? Right. So for those, you know, people who are eligible to be included, we are also carefully check against their eligibility in terms of to receiving MRI scan as well, okay? Because, you know, the MRI is, you know, the scanner would release a very strong, you know, magnet force, you know, is under the scan, under the very strong magnetic field. So that's why safety is very important as well. Okay, so the focus area, of course, is, you know, the head. Okay, so focus on the brain. So the participant would be lie down like this. Okay. Right. So a bit information of, you know, who did participate into our project. So majority, we finally recruit 82 participants. Actually, we recruit more than 82, okay. But some of them are actually not eligible to be scanned by the MRI. Okay, so we collect some, you know, questionnaire data from those who are not eligible for the MRI measure. Okay, so we see, you know, for example, when compare the smokers and non-smoker, the average smoker is, you know, the orange highlight, the non-smokers are green, light green highlighted. So we see, you know, a vast majority of the people with schizophrenia has the history of admitted hospital in the past year. So their readmission rate is very high for people with schizophrenia, okay? Right. Then when compared with, you know, smoker with the non-smoker at the baseline, actually we do not see the difference between, for example, the duration of illness, you know, between the smokers and non-smokers. And the BPRS slightly, the average smoker, slightly higher symptoms of the schizophrenia when compared with the non-smoker at the baseline, okay? So one of the key findings for this study is we see the correlation between smoking duration and regional brain volume. You see the brain volumes are actually negatively related to the smoking duration. That means the longer the smoking duration, the brain volume is, you know, lighter. Okay, so the brain volume loss is more severe in that sense, okay? We see the significant differences here, okay? So this is again another you know, in the images to show the smokers, you know, brain images. This another finding is in terms of the consumption, cigarette consumption per day, together with illness duration, okay, among the 81, you know, participants. So for those who are never smoker, the cigarette per day we use the number is 0, okay. So that's why we can count the total number of cigarettes per day per the participants times their duration of illnesses. And finally, we found the similar observation as the duration of the smoking, okay? So against the brain loss is more severe when the people who consume more cigarette and with the longer duration of the schizophrenia. So there is a, from this result, there is a dangerous synergy. Okay, smoking and illness duration. For example, a significant interaction effect was found. Okay, and among patients with a longer illness duration, smokers saw significant greater volume loss in brain volume, okay, when compared with never smokers. Okay, so the takeaway message is smoking may accelerate disease-related brain atrophy. Okay, another, this is, yeah, right. So this is some example, the images that I showed you to see the structural MRI comparison from 2 schizophrenia patients, okay? So to let you know, for example, patient A with the short smoking duration, 3 years, with some minimal changes on the brain area. But for patient B, okay, on the right side, the long smoking duration is 42 years. Visible widening of the postcentral area, that means a thinning in the right region, brain region is indicated. So that's why this another, you know, evidence that we definitely found, for example, there is some direct smoking duration effect, okay, because the longer time smoking only, and also the higher consumption of cigarettes. So this is direct effect, but there is synergetic interaction with the illness duration as well. Okay, so that's why, you know, for helping people with schizophrenia, maybe there is a more challenges for helping general population people to quit smoking. Okay, because you know, at least we see the harmful effect is more prominent among the people with schizophrenia. Okay, so I went extremely fast. Yeah. There is some you know, observation. For example, when compared with the literature, for example, we see there is a compound vulnerability, the direct and acceleration, interaction-specific pathology. So smoking actually as a disease modifier, so amplifier the health hexes among the people with schizophrenia. Another thing is they alters the trajectory, okay, because they might, smoking might amplifies the degeneration, okay. So that's why maybe the brain loss are due to not only normal degeneration of the brain function and brain tissue, but smoking might be, amplifies, speed up the degeneration of the brain among the people with schizophrenia. So that's why, the nicotinic, schizophrenia interplay is observed. Okay, so there is some implications and future direction. So one is, for example, for clinical implication. So I think smoking cessation, must be a core component of psychiatric treatment for people with schizophrenia. Okay, and medical doctors have to carefully titrate the medications for the people with schizophrenia who also smoke as well. Okay, yeah, because it's not just about health disease, not just about cardiovascular disease. Okay, it's about the interplay between, schizophrenia and smoking. And it is very important that the appreciate cause of the helping, because we see the preference of people with schizophrenia is not high. It's less than 1% among the entire population. Okay, but the hospitalization rate is the highest among all the mental health people with mental health disorders, and the duration of hospitalization is very high as well. Okay, and the quality of life of the individual people with schizophrenia and their family caregivers are greatly affected by the people with the disease and illness. So we really need to think twice about this public health measure. So future research, because we see there is some limitation, even though we are using, structural MRI, apart from using self-reported, for example, symptoms of schizophrenia, self-reported smoking histories and behavior as well. But still, if we can, conduct a longitudinal study, cause and effect relationship can be established. Okay. Another is, can quit smoking reverse these structural changes? Okay, I see some of you are actually, but in general population, okay, we see the benefit of quitting smoking, okay, in terms of the lung function, okay. For example, we see the lung function loss among the smokers, up to year about 40 age of at 40 or something. So the lung function loss among the smokers is up to like 50% of the normal function when compared with the people at the similar age who do not smoke. Okay. But if the people can quit smoking right away, for example, even 1 hour, because smoking actually, there is a byproduct of smoking, what we call the carbon monoxide. The carbon monoxide would like to partner our hemoglobin, attach to the hemoglobin, then engage the hemoglobin, then prevent our body to grab hold the oxygen molecule. So that's why smokers usually, they would have more easy to shortness of breath when they have challenging of, for example, climbing high or doing physical exercise. So one way is, even though, people quit smoking right away, then they can, breathe more effectively already. Okay, so from the evidence, from the literature, we found that if people can quit for more than 3 years, then the possibility of, different diseases. If people can quit more than 10 years, their possibility to acquire, for example, cardiovascular diseases might be relatively similar as the people who do not smoke, who had never smoked. So those information, I think, is important as well. Okay, so that's why I think if we have the chance, okay, to look at the brain structure loss can be reducible. Okay, when people can quit smoking. So this is another direction for investigation. Another direction for investigation is the biological mechanisms, okay? So now we are actually do not quite sure how come, the brain structure can be changed by, taking cigarette smoke. So one way can do it is by using, task-based functional MRI. Okay, this is another part of my study. Okay, that study including, create a task during the people under the scan of the MRI. Okay, I actually developed 60 pictures. During the people lie down under the scanner, okay, I present 30 images, 30 pictures with no relationship with smoking. Another 30 pictures is smoking-related pictures, okay? And then give the participants a controller to indicate their level of craving. Okay, so this is can see the level of craving in related to the stimulation of smoking. Okay, so we can see the changes of brain connectivity in that way. Okay, another is after the smoking cessation intervention. Interesting. Our study actually using a psychotherapy called acceptance commitment therapy that helping the individual identify what would be the most important things for them to quit smoking, or who would be the important person to know if he or she has been successfully quit smoking. So the meaning of quit smoking for him or her. So this is one way to helping the people work towards the direction of value-based, behavior. Another thing is a lot of smokers smoke because they are, their thinking sometimes would be having some thinking to explain why they need to continue. Okay, so one way might be I heard some of my clients say, Dr. Mac, you say smoking is harmful to health, but do you know Deng Xiaoping? Deng Xiaoping, who smoked quite heavy, but he can live, till 80 or something. I don't know, quite a long life living, I think. So that's why I don't scare about it. So something like that. Or someone might say, you see, you say there is 90 something% of the people with lung cancer are smokers, but there's 10% or some people who are not never smoked, but they have lung cancer. Okay, so I may be the the one, you know, who might not acquire this kind of things. So but eventually those who speak this kind of things to me are those who attend my clinic to seek for smoking cessation services. Okay, so that's why we should very understand the ambivalence. Okay, so in one hand, they see the problematic of continuous smoking. But on the other hand, because of the craving, because of the withdrawal symptoms, and because of, you know, for example, for schizophrenia patient, because of the negative, you know, symptoms, they feel boring, they feel, you know, cannot think, then they would like to do something to enlighten themselves. So that's why I think, yeah, we, as a public health, you know, provider, I wanted to encourage all of you, do not quit to help people to quit smoking. we need to find out more effective ways to do that. Okay, can you see the screen? All right. So the first question is, what is the main reasons why smoking causes brain volume loss? We have already shown them. We already. OK。係。OK，好。咁嗰啲 choices 咧？呢個係線上問嘅問題。哦，線上問問題。OK，I see，I see。我以為係佢。OK。So, what is the main reason why smoking causes brain volume loss? Okay. I think this is a very good question. As one of my implication for future is to thinking about the future study is about the mechanism of, you know, brain loss due to smoking. But one way might be because of the cognitive connectivity. Okay, the brain tissue activity. Okay, for example, if the connectivity is decreased, maybe the brain volume would be reduced as well, I guess. But we need to find out. Okay, and if nicotine affect the brain structure, why only some brain structures were affected? Okay, but not the other areas. Okay, as far as I know, you know, the brain different brain regions might be responsible to different functions or different activities. Okay, so still I cannot answer this question right now. Okay, because we need to explore further about the mechanism of, we now have the ability to see the phenomenon, the relationship between smoking, in particular to quantify the duration of smoking and also the duration of the illnesses together, to see the interaction between the two and on the effect of the brain structure, brain volume. So that's why I cannot completely answer your question right now. You know, whole brain should be affected. We see, you know, from the slides that I showed you, we see that different part of the brain are affected. Okay, including the white matter. Okay, or also the gray matters. Okay, prefrontal regions and the and other regions as well. So I think our structural MRI are usually having a whole brain scan. Okay, so that's why we have the ability to see, different areas of the effect on different area of the brain. Okay, but we need to carefully look at, maybe, for example, some regions might be affected. If the effect is less prominent, then we might need to have a larger sample size. Now we only got 30 subjects who are smokers, okay, compared with 51 subjects who are non-smokers. Yeah. Or you are really question I got there. Yeah. Yes, yes.
Hello, I have two questions for you. As I'm in the NGO sector in the community before, I know there's two models for the smoking cessation program. One is the nurses and the for the patients to go back and to have that kind of program run by NGOs. And another model is the traditional Chinese medicine model. So what's your view on these two models? Are they effective, or right now the numbers, I just checked out the government report, the numbers are decreasing. So
Yeah.
I don't know the effectiveness of these kind of models. That's the question number one. Number two is are there any study of the smokers who works in particular industry? Well, many workers, for example, in the construction industry, they have this smoking habit as a social talk, so they cannot quit smoking because of this kind of job reason, work reason. Are there any studies, or as nurses, do you pay attention of this kind of working factors? Thank you.
Yeah, there's some, maybe I answer you the second question first. There's some occupational related, preference as well, and cultural influence as well. For example, my clients who are actually are businessmen have to work across borders in Hong Kong and also in mainland China. He is a boss of a factory with many employees in the factory. He's already a boss, but in China, the culture is if the employees wanted to do good for the boss, they would thinking about giving him or her some lovely things. Then they thought, they put cigarettes as a gift. Okay, so my client is in Hong Kong. He does not smoke, but in China, he felt he very difficult to refuse offer of cigarettes from other people. He think cigarette consumption is a culture, is a friendly relationship. So that's why we see cigarette dependence could be associated with three types of dependence. One type is physical dependence. Physical dependence is related to nicotine. Nowadays we see one stick of cigarettes might contain more than 7,000 substance in one stick of cigarettes. Okay, but only one thing is addictive, which is nicotine. Okay, so this is physical dependence. Okay, the other second dependence is psychological dependence. Okay, psychological dependence is, for example, I got one client who's a mom, who's taking care one baby and one kid. Okay, one is about less than 1 year old. Okay, another is in kindergarten. Okay, each day she take care of 2 kids, carefully and get well. And when she bring the elder kid to the school, then she will go to the library to borrow books and do all kind of good things for family. And then before the elder son kid to bring him back to the school, he back home to clean the house and then things and then prepare the lunch before the elder son back. And then at this time, everything is settled. And then she will sit on the sofa and relax and see how appreciate her work to the family. So she come to me, firstly, I think, it is easy because she's just taking 5 sticks of cigarettes per day. Another guy is taking 40. Originally, I thought the 41 might be more difficult to quit. But for this month, because the smoking is like a recognition of her contribution to the family. It's like a reward, her recognition. So that's why very difficult, right? The third dependence is the social dependence that I'm talking about, the businessman. So that then I wanted to answer your first question. So you see there are 2 smoking cessation intervention method. One is nicotine patch. Okay. So I see the most problematic one component is nicotine among the 7,000 substances in one cigarette stick. So that's why people are very careful. Okay. They use nicotine replacement therapy to help the people to quit smoking. Then if by the time they need the treatment of the NRT, then they can quit another 7,000 substance. Okay, that is something like metal, harmful things, okay, carcinomic agents, everything. Okay. But the problem is there's some limitation on NRT because if people smoke, once they take 1 mouthful of cigarettes, then it takes less than 7 seconds. It is like immediately the effect of the smoking soothing here. But the NRT secretion is steady. So when people who got craving of smoking, then the craving is that, then if take a mouthful, then subside. So comfortable. But the NRT is like that. The release of the NRT nicotine level is like flat and does not respond to, for example, now my boss is just going on me. So I'm so angry. So I need to take a cigarette to calm my nerve down. But NLT does not help with this. Okay, so some people might think about others. The combination of 2 types of NLT, nicotine patch because the release is steady. Another is supplement with nicotine gum. Okay, 香口膠, it's just like a 香口膠, but the nicotine release. Then it's a little bit more helpful because that is used on demand. Okay, so I mean, no matter which way of nicotine replacement therapy or which way of smoking cessation therapy, the participant need to thinking about to control as well. Okay, So another way is, other psychotherapy to combine with NRT at this moment, at now, this is the most effective way, psychoeducation plus NRT at this point. But the quitting way still less than 20%. Yeah, so that's why I continue challenges. Yeah. Any other question? There you go. Okay. Advice. My friend's child, a teenager, was claimed ASD and ADHD by doctor and advised to regularly use the medicine tablets that stayed on the to cure schizophrenia. Does that mean ASD, ADHD is related to schizophrenia? If yes, are they all affected by smoking? Yeah. I think medically, in terms of the diagnosis, they are two different things. Professor Yi would be talking about some medications for people who have this schizophrenia later on. I hope he can help to answer.
About smoking. I smoke and I
Yeah.
smoked for many years. I've had gum. I've had the patch as well. Yeah. I
Yeah.
still smoke.
Yeah.
It don't work.
Yeah, maybe later on you can help a bit about the medications, but to my understanding, some of the medications are for mental health is not like specific medication for specific medical diseases. Okay, so it is like, to tackle with the mechanism of the problem. So that's why, you might have the impression that, this medication is offered to people with ASD or ADHD, or because some of the medication might be deal with the symptoms. Okay, for example, like if people with cold or influenza, they might need to have to take for example, paracetamol for dealing with the symptoms of headache or other things, or fever. Smokers who constantly smoke over a period of time would be suffering from brain volume loss. However, what if the people who only smoke occasionally, say once a week? Is there any research related to non-frequent smokers? Yeah. I think some people would like to focus to see, actually, my study is touch on, because I actually calculate the consumption. I use year pack year to calculate the overall duration of smoking in related to the daily consumption as a quantifiable number of use. So this is one way to do that. Of course, for example, if people who are occasional smokers, maybe in terms of the dose is not much, okay, but I would still encourage the people who are even experimental of smoking to stop smoking. Because you see, everyone actually start with experimental smoking, only 1 or 2 mouthful, or 1 stick of cigarette to share with few friends at the beginning. And then occasional smokers. For example, I work for some schools. The school principal invite me to help their children to quit smoking. Those school children who only smoke Friday after school and Saturday and Sunday, and then back to school from Monday and Thursday, they do not smoke at the beginning. But after school, if they do not have a chance to smoke, they feel a little bit lost. So even though occasional smokers is already hooked by the cigarettes, okay, so one day experiments, occasional, another day would become regular smokers. Yeah. So from your study, the reading of exhaled carbon monoxide over non-smoker is around 5. It's normal value. Yeah. That regarded as a normal value. Okay. Because there is contamination of air. Unlike cotinine, cotinine is the byproduct of nicotine. Okay, exactly the byproduct of nicotine. But carbon monoxide is an incomplete combustion of something. It could be contaminated by the environment. Like if the people working in near the harbor tunnel entrance, okay, or at PolyU, maybe we are exactly inhale some carbon monoxide when compared with other people as well. Okay, yeah. So that's why there is regarded as above 6, or some study would regard about 10 would be excessive carbon monoxide. Yeah. But I think, for my study, I usually set 6 or above as, have a concern about the cigarette consumption. May I know how the study is applied in clinical treatments? Yeah. The application for clinical treatment as my last slide about the clinical implication. Okay, one is in particular helping people with schizophrenia. I think the healthcare professionals have to consider smoking is one of the core health issue for maybe comorbidity issue for the people with schizophrenia. Okay, because that may affect the demand of the medications and the deterioration of the people with schizophrenia's situation. Yeah. So would like to pass the time to.
Thank you, Dr. Mark. Should I start, or you want to say 1 minute break or something? These questions are not for me.
Bye-bye. Thank you.
Thank you. Oops. Turn out. Okay. I know you guys are from mixed background, various background and so on. So I was thinking about what to talk to you about. And I thought I'm going to give you some generic overview of what I've been doing in terms of research, partly related to mental health for the last 20 years. And this topic is quite nice, that one of the focus is tied to schizophrenia. The work that we can use this. So it's nice that Dr. Mark covers some of the background already. So you all know what schizophrenia is. It's a very devastating disorders. Although it's 1%, affect 1% of us, its effect is long lasting and it affects people who are in the prime of their life. So it destroyed someone's life from early adulthood. So Dr. Mark is a nurse. I'm not a nurse. And she talks about, how to help people. In her example was about cigarette smoking. They have various kind of comorbidity. They also have a high incidence of other addiction as well, not just cigarette. Just cigarette just happens to be highly, highly, highly addictive. I can tell you from personal experience. But what I want to talk to you about is I come from a more pure science or neuroscience background. So first wanted to talk to you is in terms of psychiatry. I show you this picture. This is Emil Kraepelin, who is supposed to be or generally believed to be or considered to be the father of modern psychiatry. And one of the things that came with him is really starting to think about psychiatric mental disorder in biological terms. He made great efforts to try to look for those changes in the brain. In those days, there's no medication. He lived in the psychiatric hospital with the patients 24 hours a day. He would have a place to stay as well. So he has lots and lots of clinical experience, and schizophrenia is a condition that initially defined by Kraepelin. As I said, he has a very, he wants to look for biological reasons. And I said he couldn't find it. Instead, he finds something else like Alzheimer's disease. In the sense of what's wrong in the brain. I'll mention a bit later on, something related to that. But I really want to mark the so-called the medical model that nowadays very much in the profession is that we think mental disorder is something wrong with the brain. And it can be treated as any other disease. So you look for the cause, look for the biological cause, and correct it. And you should correct the disease like any other disease. This is a philosophy. So I wanted to start with that. And for a long time, there's no such interventions available. And people try, and this is just some example of people try to basically shock them. And it was really out of some unfounded observations, unfounded reasoning of some occasional observations. And in this case, it's a bit like observing that people who are epilepsy and schizophrenia, they tend not to have schizophrenic or psychotic symptom when they have the fit, when they have epileptic fit. So people just put the things two together and say, well, if I want to suppress or remove the psychotic symptom, I induce epileptic fit. And this is almost the reasoning behind the so-called shock therapy. They shock with electricity. They also shock with insulin. So they give you so-called insulin shock to deprive glucose basically to your brain. These are very, very devastating treatment. I don't want to show you the video because it's not very pleasant to look at. But this is something that has been tried. My mom, who is a psychiatrist, told me that in the 70s and the 60s, they introduced this to Tingside Hospital. And there were patients whom, after inducing insulin shock, they couldn't bring them back and die on the table. So this is just, I'm trying to say that there's very, very little we can do. And one thing happens in the 60s is that they suddenly have a drug. And this is the first drug promising that has real effect in controlling schizophrenia symptom. So for psychiatrists, this is like, now they're doing they're proper doctor now. They have drugs, they have a drug cabinet. So in those days, like Dr. Mark said, those drugs are really symptom orientated. So at the beginning, they have basically two types of drugs. They call it minor tranquilizer and major tranquilizer. So for very, very serious like schizophrenia symptoms, it would be like major tranquilizer, essentially you just sedate them. And minor tranquilizer are things like diazepam that they use to treat like anxiety and so on. So they They used to have nothing, and now they have this big blade and a small knife. At least they have something to cut things with, to sort of tackle and try to claim that they have some kind of biological approach to treating psychiatric symptoms. This is just a little timeline that show you from the 50s, when this is the paper that when one of the early clinical trial to show the efficacy of the drug, quite promising. And what has moved since then to this paper, this is, I think, towards the beginning of the 21st century, of the from promising to something like we have like in so-called first generation, and then we have second generations antipsychotic. So here I put that here. This shows you drug like clozapine, and also similar drug to clozapine like olanzapine, which is a kind of a Me Too drug. And also I should mention that such drugs like promising are really discovered by chance. Many psychiatric medications are discovered by chance. For example, like lithium treatment for manic depressive were discovered by chance. But then we got stuck, and people were using it. And very much the present state, this is a paper back in 2023, indicating that basically psychiatric drugs works. With only a few exceptions, current psychiatric work via the same fundamental mechanism as their first generation sort of discovered by chance kind of drug. When chlorpromazine was first used, people found it efficacious and they used it. They didn't know how it works. It took some time and to work it out. And that one of this person was Arvid Carlsson in Sweden, who later got the Nobel Prize in 2000. And he worked out that the drug was active on a specific target in the brain called the dopamine system and blocking the transmissions of the dopamine system. And it was based on this came the first idea that schizophrenia may be due to overactive dopamine. And actually, this is a silly way of thinking it. You guys were talking about having pain and then you take paracetamol. No one would say that my pain was due to paracetamol deficiency. But they run out of things, so they have this kind of formulations. And as people like me who do research and try to look for new medications or try to model the disease, we would nonetheless try those hypotheses. But at least we have the attitude to try to test it. So this is one thing I want to point out. This is an even more recent paper. So this is, I think, in 2025. I think it's in May. It's a paper by David Nutt. He's a very famous psychopharmacologist, neuropharmacologist, and often a critic of the UK government. And here he said, for a lot of psychiatric conditions, depression, schizophrenia, anxiety, schizophrenia, ADHD, the pharmacological classes of medicine discovered were through serendipity in the 50s and 60s, and they were still being used. So what the message is that in terms of drug discovery for mental disorder, actually there's not much to show for at least 50 years. So this is essentially what I would start the story with you, is that we are in a very bad state, actually, in terms of coming up with new biological or new drugs to help psychiatric patients. And in this case, I'll talk about something related to schizophrenia because that's what I used to work on. So you probably have some idea that certain neurotransmitters involve schizophrenia. We think that the disease, certain symptoms, like positive symptoms, are related to certain neurotransmitter system being overactive. And one of them is dopamine. And many drugs that are effective in controlling psychotic symptoms are blocking the dopamine receptor. And this we know. But these drugs are good in controlling psychotic symptoms, what Dr. Mack talked about in terms of positive symptoms, because they were abnormality by the presence of something, so we call it positive symptoms, in contrast to negative symptoms, which are abnormality due to the absence of something that's normal. So this demarcation of positive and negative is a neurological concept that goes back to Herling Jackson. and very much borrowed and then applied to describing schizophrenia. And there's currently basically no drug that could help negative symptoms at all. And negative symptom is a major problem in rehabilitation, in allowing people with this disorder to integrate back to the society and have a productive, meaningful life, because it disrupts their work. And this time, for example, in our current time, when people have serious psychotic problems, they can take drug and they can suppress it. Except, of course, you always have a few people, a few patients who may not be responsive, and this probably applies to all sorts of disease, that you have so-called drug-resistant patients. But for negative symptoms, basically there's no medication that can help. So people always try to look for new ways a new idea that may be able to help. And this, I want to show you a very simple, to introduce you a new concept that people have been trying about 15, 20 years ago. I wasn't in a drug company. I wasn't involved from the development from a pharmacological point of view, but we were testing the same idea, this new target, using genetic engineered animal. And the idea is targeting a different neurotransmitter system, not the dopamine, but the glutamate system. And then the glutamate system acts through different receptors. And we particularly focus on the receptor type called the NMDA receptors. And the NMDA receptors is famous also particularly in terms of neuroplasticity, because they can change the efficacy of synaptic transmissions. When you use it, then basically you can see changes in the synaptic efficacy. So when people know more about the so-called molecular pharmacology of these receptors, it turns out that this receptor has a very magical way of functioning. I try to use the pointer, see it works. Okay. It's a terrible lag. So if you look at this, this is basically the close-up look at the receptor. And essentially there are two little balls there, the brown one and the blue one. And that basically tells you that this receptor needs to have two keys to open. One key is the neurotransmitter glutamate. And the other key is like when you open up this locker in your bank with your jewelry and your gold. You need to have another key. So you need to put both in, then you turn and then you open. And then the other key turns out to be another amino acid called glycine. And you need to have both keys to open. If the glycine is not around, if the banker's key is not into your deposit box, with your single key from you, you're not going to open it. And it seems that this could be a way that we are able to enhance the transmissions of this neurotransmitter in terms of opening this receptor. Because it turns out that people found out that the glycine level is normally regulated so that the glycine site, we call it glycine B site, is not saturated. So if we make the glycine more available, then the probability of this receptor opening will be higher when there is a neurotransmitter coming, when there's a signal coming. So this is a very nifty way of trying to enhance the neurotransmitter system, because it would enhance only when the system is activated. When there is a signal, when there's a message trying to pass through, you enhance the probability of that message passing through. When there's no message at all, you're not going to interfere with the system. You so-called remain silent. So it has the ability to have this use-dependent enhancement of a particular neurotransmitter system. It's a very specific interventions when we apply knowledge of molecular pharmacology. So instead of using drug, I don't test the drug. We create an animal that actually disrupt one of the transporter that remove the glycine from the area. This is called the glycine transporter. It happens to be the glycine transporter 1. There are many different transporters. We target glycine transporter 1 because they like to express in the relevant area. So I use a molecular method in animals to imagine, to have a situation like, what if you have a drug that could do so and so? We create the animal. And then to predict what if you indeed are able to design that drug? What would be the expected effect? My colleagues at the time would always say to the drug company people, say, drugs are never selective, but my animal could be as selective as I want because we disrupt the gene. And here, we also disrupt the gene in the sense of the cell type. We control what type of cell that will remove the genes and therefore remove the protein and therefore enhance transmissions. So to cut a long story short is to tell you that in the animal model, we did see antipsychotic property in this animal model. And we also see some signs of improvement in some selected cognitive tasks. We don't see any signs of improving negative symptoms. For the drug company, this is from Hoffmann La Roche in Switzerland. This is a drug that they were marketed at around the same time. They were doing clinical phase 1, phase 2. Phase 2 result was beautiful. The share prices was going up. And then they moved to phase 3. That's about the time I left Switzerland. Then I was in the States. And then they finally released a 6-center multi-trial results. And you can go through briefly, they try different doses, but ultimately you would see basically the critical line is let me see, which one is that? The bottom line, failed, discontinued, failed, discontinued. Only this one, they found just significant effect. And what happened is that they sold the drug. They actually sold the drug now to a different company. So what I'm trying to tell you is some experience. I have some journey I went through and saying that it's very, very difficult to see a new mechanism, to discover it, to test it, and then to bring it through into a possible new treatment. And another example, actually, have better luck. This is actually a new drug. Indeed, it is the first new schizophrenia drug since 1950s. A new drug in the sense of what we call first in class is a completely new mechanism. And this drug target not on dopamine, not on the glutamate system, it target the acetylcholine system. And it targets in particular one type of transmitter that acetylcholine would stimulate or would talk to, and this is the muscarinic receptor. So this has nothing to do with smoking, because the nicotine go to nicotininergic receptor. This is the muscarinic receptor. And I want to talk about this drug because of the following. This drug called Cobenfy actually is not absolutely a new drug. It's an example of a repurposed drug. And it's also a combination of two drugs. And the story is quite interesting because one drug has actually have the ability to stimulate certain receptors. So they have a theory that if they stimulate certain receptor, it will work. But then, and this theory go back to 30 years ago. But one of the difficulty is that it has a lot of side effects, because when you tinker, when you stimulate with the muscarinic system, you have a lot of side effects like, well, parasympathetic system may go crazy. And then you have a lot of side effects like vomiting and so on. And you'll have a heart problem because of you're playing with the parasympathetic system. So the way that they try to tackle with it, this drug company who market this combination, very precise combination of two drugs, is to use another drug, the trospium drug, that actually doesn't cross the blood-brain barrier. So it stays in the periphery, but it blocks the effect of the active drug that you want to act in the brain. So now you have this combination, is that the drug appears to have some selectivity now to act on the brain, and then you get rid of the side effect. So this is like an old drug, an old idea, and then being repurposed. Actually, the drug xanomeline was not developed for schizophrenia at the beginning. It was developed as a possible treatment for Alzheimer by Eli Lilly. And they subsequently sold the compound, and then this drug company repurposed it and package it, and then have this combo, and then to have a new drug. And this is a big news because this is, as the title said here, is the first class of drug since the 50s for schizophrenia. And here it also shows you that the drug has efficacy to improve not only positive symptoms. So this is the one of the RCT that they published. They don't usually publish all the data, so I'm only able to find this one. So it has reductions of symptoms on the positive scale, and also reduction of symptoms in a negative scale. And this is usually a very important drug effects. And this is phase 3, so they passed, and then FDA gave them the go-ahead. This is the guy who came up with the idea that the acetylcholine is a possible target. As he says here, he's in Australia. The idea was 30 years ago, and it took 30 years basically to have this idea really make an impact. It's slow, so this is another thing I want to tell you, is that it's very slow. So this is more or less what I want to talk about the drug, and what I really want to tell you is that it's very difficult. And then I want to tell you there are other means beyond the drug, but also in terms of biological basis. It's more like in terms of fixing the brain. And in recently, this is all within this year or last year. So on the left is basically to illustrate to you an approach that people took to try to achieve what they call gene therapy. So if you have read the news, you probably know a few months ago, there was a trial for Huntington disease. And this is gene therapy. So they have a system that they package certain messenger RNA in a virus, what we call AAV virus, adenosine-associated virus. Then they inject it directly into the brain of the Huntington person, the person with Huntington disease. And we know exactly where we should put it, because usually if you know this kind of neurodegenerative disease, Huntington involves the degeneration of the striatum. And we also know, in a sense, why they have these degenerations, because I remember I was probably in secondary school when they discovered the gene involved. And the gene is called the Huntington gene that is implicated in Huntington disease. And they know exactly what's wrong with that. The mutation involves a repeat in the genes. We call the CAG repeats. And with these repeats in part of the genes, it turns the protein toxic. And it's also very strange. It's a very interesting system because you can have mutation with more or less of these mutated repeats. The more the repeats, the more toxic the protein becomes. And the idea is basically they're going to do they're going to transfer genetic material into that part of the brain that will be that suffer from the expressions of these mutated genes, and then they block these expressions. And then this is only actually I think it's phase 1/2. They also look at efficacy, and it's able to slow down the progression of the disease in terms of the progressions of the symptoms, improve it by 75%. So it's slowed down by 75%. So this is an example of gene therapy. And when I read about this, I somewhat remember is that I used to put such virus into animals and also trying to introduce genetic change in different parts of the brains. And essentially they're doing, technically, it's not that different from what I did. If you want to know more about technicality, actually, there's still room for improvement, because the genetic interventions that they have is actually blocking all Huntington genes, all Huntington gene expression, but not focusing specifically on the mutated genes. People with Huntington disease have 2 copies. Genes, we have 2 copies, right? But usually they have 1 copy gone wrong. And this is suppressing actually both, the good copy and the bad copy. And actually you need that protein. The protein actually has a normal function. Most protein has a normal function. It's that the mutated versions happens to be toxic. And this manipulation is actually reducing expressions of both types. So you can see an improvement potentially already. On the right side is another kind of biological treatment trying to fix the brain. And that now is in the case of Parkinson. It's another neurodegenerative disease. We know which part of the brain the degeneration happens, and that is the substantia nigra. So the substantia nigra's projections to the dorsal striatum and the putamen which is dopaminergic, is degenerated. So there's not enough dopamine signal to the striatum. So now what they try, and the idea is really the news is really trying out the idea, and it sort of is feasible, is to use stem cells. And that week, there were 2 papers back to back. One paper derived a stem cell by turning so-called induced polypotent stem cells. So you need to harvest a cell from you, and then they use method to turn it back into so-called polypotent stem cell, meaning that a stem cell is called a stem cell because it has the potential to develop into any cell type. So this is the inducible to produce that cell line. And then the other is actually use human embryonic stem cells. So you actually harvest from embryo polypotent cells that has the ability to develop anything, from brain cells to skin cells to whatever. So there was 2 papers that week in Science, and trying to do that and injecting into humans, into the striatum, where the dopamine is not sufficient. And of course, the idea is that you put those cells that has the ability to develop into any cells, that when you put it in that environment, they would turn into functioning dopamine releasing cells, and then fix the problem, fix the reason of symptom production. And if you're thinking, man, you will know, well, this is not exactly fixing the brain. The problem involved is the loss of the cell in the substantia nigra. Why are you putting the cell in the striatum? Why are you not putting the stem cell into the substantia nigra, which is in the brainstem? Because, you know why? Because it's extremely difficult to have the cell finding the way back from the substantia nigra to the striatum. It's a long way. It's like from here, I go back home to Saigon, you told me. It's a long way, and you would get lost. And previously, I was also involved with other labs that actually trying other methods to try to lead the way. And it's extremely difficult. But you can see that at least the principles of stem cells is being tried. And this is the idea of trying to fixing the brain. And in some sense, it's no more complicated in terms of the philosophy behind or the hypothesis behind than trying to use the drug. And tends to be this kind of treatment, trying to fix the brain, is more often you can find it's making its way into things like neurodegenerative disease, because neurodegenerative disease, typically, we know the cause. And Huntington is a very good example because we know the exact genes. In the Parkinson, we know the exact pathology. It's very specific and localized. So those are the situations that you can see probably new development. Okay, Alzheimer's is probably much more difficult. But we also, some of you probably have heard that there are immunotherapy that you can give antibody to people now that actually binds to early polymer aggregate of beta amyloid to slow down the disease. But it can only slow down the disease. It cannot really reverse the time. Probably the same for the Huntington example I gave you. You could slow it down, but it cannot fix it. Fix it means turn back the clock, restore it, so to speak. So I want to end and basically trying to tell you that it is not, from a biological point of view, as someone who studied the mechanism of the disease as well as the mechanism of potential cure, all this biology are very interesting. But after I came to this university, I get in touch with people who try to make a change to the society, try to make a change to the life of patients like Dr. Mark. And I realized that, especially here at Poly, because Poly University, they excel in many other approaches in engineering, in data analysis, computer information technology, and so on. And there are opportunities that those technology could drive or help in terms of mental health. And here I just list a few, like they're applying like data-driven big data to try to predict risk, and use electronic method to try to collect a lot of data, wearables, and so on, And this idea came from someone called Thomas Insel, who used to be the head of the National Institute of Health in America. He quit his job one day, and then he went to work with Google's and have this idea is to collect a lot of your data from your phone and trying to make predictions about all sorts of healthy related so-called signals. And in that sense, to predict and to help you to prevent, therefore. The other thing is knowing more about you in this way may help about tailoring medication, tailoring treatment. And this is to advance personalized medicine. And as I said, with predictions come with the possibility of preventative strategy. This is a quote I put here from the book. I would recommend people interested in mental health to look at that, read this book. In the sense, it's saying that we can't keep waiting for people to tell us they're depressed, that they're sick, that they have problems. We need to measure so-called a signal before. In that sense, it's much more effective. Because one of the things I think I have shown you is that treatments are difficult to come by. And mental disorder is very difficult to cure. It's not the normal sense of cure, like you may have a virus, you get rid of the virus, and so-called your body back to before. All mental disorders sort of left indelible sign to you in terms of your functioning and so on. So it's a life-changing thing. And probably a better way to help is to prevent the change from happening or to reduce the impact of those changes as early as possible. So it's sort of a more human approach, I think. This is the quote actually I get from the book that actually I think makes also a larger, from a more wider perspective. So this describes someone saying, I had to decide, do I want to kill myself or do I want to see a psychiatrist? And went on to say, well, I hated myself enough to want to die, but not so much that I would become a mental patient. And what this really illustrates, I think, this is not something I can fix with a drug or do a surgery or do a gene therapy. This tells you that society has to change. Something in the society must be, whether you call it stigmatization or you call it cultural differences, must be stopping this person to simply go and see a psychiatrist. And pick the alternative is maybe to kill myself. I'd rather kill myself than to see a psychiatrist. I don't hate myself sufficiently to justify me to go and see a patient, to become a patient, to have that label. And I think when I think about things like that, it really brings me out from the lab, away from all the drugs and all the things I do to my animals, and think about what impact that you can make. Not me hiding in the lab, or my studio work nowadays work in the drug company and designing drug. And probably things like that every one of you can contribute will bring about real changes. Whereas me hiding in the lab for over 20 years, I sort of get close to a concept that may bring a new drug. And then, of course, it failed, which is a story about that transporter blocker. So I hope this leave you with some idea that for you to think about. And thank you very much for your time. And I'll probably give some time that, if you have questions before the break. Thank you. Success rate about stem cell therapy in case with any Hong Kong trial. No Hong Kong trial for sure in terms of stem cell. There was a phase 1 and 2 stem cell trial. So it was not, the phase 1 and phase 2 are not primarily efficacy. But of course, I don't mind looking at efficacy. Phase 1, phase 2. Phase 1 is primarily for safety. Phase 2 is really for early efficacy. So they're already trying to jump the gun a bit. So FDA allow a phase 1 and 2. Next, no more? Yeah.
sorry that this mostly are silly questions, and I would like to ask in Cantonese.
Yeah.
我想問 mental health 咧，好多時都係靠一啲人，即係靠 symptom 先去 detect 到呢個人有問題啦。
係
咁但係有冇可能話我哋可以透過一啲即係佢好似例如胰島，即係點好似糖尿病咁樣，你胰島素唔夠，我就係已經係糖尿病。
Okay.
但係 mental health 有冇得 measure 㗎呢樣嘢？
The short answer is no. But there are exceptions, really exceptions, for example, like the story of Huntington. So there are people who know that they inherited that default, that 40 genes from their parents. And they can even, hopefully you only have one copy, hopefully you don't have two copies. And then depending on the repeat, because they can also now, we can actually genotype and actually work out how bad your mutation is and essentially calculate your risk. But then say one of you have this already, but you are not symptomatic because we don't know when this is going to turn up. And then you start to have these symptoms, and it could actually be very quick. So people who do that also have to have gene therapy, not gene therapy, but gene counseling. They need to plan ahead what they do. If symptom kicks in, what do they do, and so on. And some people don't like to know. Yeah. And in general, psychiatric disorders still remain symptomatic level. I remember DSM-5, I think mentioned in one chapter is the neurocognitive disorder, which is essentially dementia and neurodegeneration diseases. This is the only chapter in which that some of the disease, we know the mechanism, but not as diagnostic. Yeah. Because for example, like the Huntington, if you have the genes, but you're asymptomatic, will you go and see a doctor? The first thing, what would the doctor say to you? What can I do for you? What is your complaint? So, but I have a mutation, you don't go. A bit like having hepatitis B. You may be a carrier. Yeah. Are you happy with my answer? There's no silly answer, so you can ask whatever you want.
都用廣東話講啦，唔好意思。其實
No
我屋企人都有 genes 嘅問題，一啲即係 DNA 缺失咁樣樣。咁佢 eventually 就真係出現咗思覺失調嘅問題咁樣樣。咁其實我諗可能都係你嘅頭先所講嘅嘢，即係好貼近佢嘅故事咁樣樣。
我唔知咩個 DNA 缺失。
一種叫 withdrawal symptoms，即係一出世就係你好似唐氏綜合症咁樣樣，你會少咗一啲 DNA，或者多咗一啲 DNA 咁樣。咁佢當然就少一啲啦咁樣。咁就去到一個程度就係喺最近出現咗 mental health 嘅問題咁樣樣，咁我哋同醫生傾過，即係話呢度係一個可能性嘅問題咁樣樣咯。咁但係我哋當佢知道，即係好早之前已經知道話冇咗一部分，即係佢係一個潛在問題嘅時候，其實都係冇辦法，醫生都同佢講冇得做冇得搞，即係 DNA 問題嘅嘢就係冇得做冇得喐，你只能夠等佢出現咁樣樣咯。唔該晒你。
即係當然啦，你未有事嘅時候，你係唔會去敲門噶嘛。如果你好 engage in such behavior, they probably saying that you suffer from some kind of anxiety or being you worry about things that you don't have to devote all the time to worry about things that may or may not happen. In terms of that, you pick on a point that I didn't mention is in some sense, if it's congenital issue, then of course you have the added complexity is the development. And this is a bit like what I said about the Parkinson situations. We know exactly what pathway is responsible for the condition. But that pathway was built, was constructed through development. Therefore, I said it's very difficult to replace the cell that was lost, that was actually in substantia nigra, and trying to ask them, can you find your way back to the striatum? Because when the brain was built, it wasn't like that. It wasn't like put some cells in the nigra and then say, then give him a Google map and say, walk to the send an axon to the striatum. It wasn't like that. It was the brain was developed in a coordinated fashion to achieve the mapping that it should have. So if it is congenital, so probably it's not just missing the gene, but actually lot of other things may go wrong because you miss certain construction material, so to speak. Yeah, so it's very difficult to probably understand already how the symptoms emerge at certain time, let alone trying to find a way to fix it. But maybe one day it is possible. Because if you believe that all your mental life ultimately is your brain life, then if you understand enough, maybe we can try to so-called fix it. Because sometimes I also have this experience before is the brain is so complicated. But how come indeed you have a simple drug, a drug as simple as lithium can be effective for manic depressive and highly effective in some cases. It's just an iron. It's very cheap in some way. A very complicated machine, and all you need is to add some iron systemically. You don't even put it in the brain, and it can control highly specific symptoms. And sometimes it's the magic of the brain that I can never sort of understand. Because you can't do it with a computer. If I mess up anything, it will just collapse, right? And then I can't just put some lithium and say it will go back to so-called normal. Any other questions for me? I think I enjoy answering questions because in that way you can ask things that you want to ask. Yes. But stem cell therapy and Parkinson, any example or case study in overseas successful? As I said, it is a phase 1 and 2, so it is not up down to phase 3. So I think if you want to talk about successful from a business point of view, this is not yet to phase 3. So you have to have a good, convincing phase 2 for drug company typically to invest in phase 3. It costs a lot of money to do a phase 3, multi-trial, multi-countries, and they have to think hard and plan because they want to maximize the outcome. So they want to recruit patients that they think would really work. Okay, so a lot of art in doing clinical trial in their patient selections. So probably that answer is no. Can heavy or regular sport exercise or massage affect the brain structure and thus help lessen mental disorder? Heavy and regular sport exercise or massage. I think I know that I can generically ask it. It's basically doing some kind of exercise can so-called help lessen mental health disorders. I think in some cases it does. In a very simple sense, if you just talk about things like smoking, I'll give you an example of smoking. Addiction is a mental disorder, and I have this mental disorder, so I can talk personally. I don't do exercise, but I can easily tell you that if I do exercise, I would obviously have less time to smoke. So are you talking about treating patients with, or like me, with a smoking addiction? You're trying to help me to reduce my smoking habit, or you're trying to fix my addiction? And these are two different things philosophically, right? From a management point of view, you ask the question. So you want to help people to reduce the smoking. You may not aim at just stopping it altogether. Some are very difficult to stop, like nicotine. Cocaine probably is easier. Most people, I think, they just grow out of it. So at a certain time in your life, you have a joint. But at a certain age, you will just stop doing it. It's a bit like maybe when I start smoking, it was cool. So I really want to smoke because I want to be a smoker. But at a certain age, it's not cool anymore. And then you would just reject it. But of course, there are changes in your brain that, like in addiction, that could exercise help. If you think from a biological point of view, like if you have a Parkinson's disease, we talk about Parkinson, and then essentially you lost very specific cell type. Do you think having exercise will bring those cells back? Very unlikely. Exercise alone. Maybe there's some other, maybe exercise would help the stem cells probably a bit more integrate better. I could probably appreciate that. But to attribute exercise as some form of elixir for mental health disorder, your question is mental health disorders. You don't even specify a condition that makes it very difficult to answer. And if you ask questions like that, I think that probably points to our lack of understanding of mechanism. It's a bit like in the days when people have, just come across a compound and it works, and they don't know why, but then say it works. There's nothing we could do, but now we have a drug that works. Let's use it. They seem to think that they have a moral duty to say, I discovered this drug and it works. I have to use it. I have to save people, without understanding how it works. It's a moral issue. Any other questions? So you certainly named 3 diseases. I think there are some studies that they help, but I'm not. Now, this is my personal opinion, and don't take it as a medical advice. I'm not a professional. If you want medical advice, you have to ask a qualified person. I'm not giving you medical advice. I'm giving you my personal opinion. I think the effect of exercise is exaggerated. Not many years ago, I think maybe 4 years ago, there was a very, very well-conducted large-scale exercise study on aging and Alzheimer's and so on. And the result was an astounding no effect, no help, and if anything, it worsened. So I think there's not enough evidence actually to really conclusively to say whether it helps or not, but I wouldn't be surprised if it helps. Like I said, if I go and start doing exercise, I'll smoke less. Simple as that, right? And in that sense, you may say, I have a better performance. You may say, you improve my condition. So I think I would always want to see more evidence. With some of you guys, probably clinicians, always would have learned evidence-based. And then the other thing as a scientist, I wanted to know is why. You always want to ask why it works. Why it works. And we also want to ask why it doesn't work. I told you the story about that drug from Roche, the pilocarpine drug that didn't work. It works very nice on phase 2. Why it doesn't work on phase 3? And it works to some extent in my animal model. It also works in the drug. They also work for the drug in animals, showing evidence that it should work. Why doesn't it work when you come to the critical phase 3? No one knows. I think some people know. I ask people there, but they usually tell me, I can't tell you. Because these are secret in a sense. And actually, in that case, the drug was sold to another company. And that company actually is marketing it as repurposing it for liver disease. And it's on phase, I can't remember whether it's phase 2 or phase 3. I can't remember that drug company either. But there's another drug with the same principle by another company, device manufactured by another company in Germany, Boehringer, and that drug is at phase 3 for schizophrenia. So the concept is still there. But it's a bit like, therefore you need to do a clinical trial. You need to take the drug and test it. You can't just say, well, according to all my theory, it should work. You need to put it to the field and test it. But sometimes I think, well, maybe, I don't know, you got lucky, it's all phase 3, and then you got FDA approval, and if there is another trial, you may fail. Yeah. So you want a break, right? Before you have the Zoom part of the lecture. So thank you very much. Don't worry about the MCQ. You're supposed to be do it with AI and ask about the questions, and be careful that there are more than one answer, so it makes it more fun. And for the worksheet, it's basically some guidance that you can also interact with the AI and try to get more understanding.
Yeah, thanks a lot for joining the last part of today's lessons, and then I hope that you are still pretty good right now, because it's almost 9 o'clock. And then today we are going to share one of our experience to do I would say that a community project with our university student together with the elderly. So I'm from Department of Computing. So I'm a joint professor of Department of Computing, and also we are Patient Science. I'm Peter. Yeah, and then nice to meet you. So lots of the students may think that, hey, Department of Computing, lots of them, they are autisms, and then they just care about the computer science. They just care about the algorithm. There's nothing related to mental health or nothing related to healthy lifestyle. In fact, we are not really healthy lifestyle, right? But honestly, in our Department of Computing, we do lots of the things. We have different community projects that care about the mental health, that care about our healthy lifestyle. For example, we have created, if you are in PolyU, we have created Where My Go, Where My Go cons, we have created Wealthy Go cons, we have created green cons. So this kind of technologies, that is, we are using the blockchain together to combine with gamification, combine with healthy lifestyle to have a I would say the whole person education for all the university students in our PolyU. So that is our thinking. So one last month I changed our slide into this project. So this project is saying that we are bridging the memory using technologies between the university student and the elderly. Why I choose this project? Because it's a good example to use the cutting edge technologies. For example, we use the LLM, we use the RAG, we use the 3D construction, etc., to build a digital human for the elderly. So this project, I would say that because we only have around 30 minutes, and then I will try my best to finish all the things within, I would say that 20 or 25 minutes to discuss all the theory about our project that is related to our teaching philosophy, and then how we run our community project, run our service learning project. Another part is how this kind of technologies is being used, and then how this kind of technologies can help the elderly to rethink about their lifestyle, and especially try to improve their depressions. So yeah, the last part I will say that if we still have time, we'll go through some of our other projects. So that is our agenda. So by looking at this line, so you can find that there is a I would say the elderly on our first index page. So I guess you will think that, hey, the elderly, his face look like someone, right? Yes or no? He looks like our President C, right? Honestly, he is one of our, I would say, the elderly in this project. We interview him, we collect his digital story, and then we create a digital human for him. He doesn't look like our President C. But when I upload our image to the OpenAI and then say that, hey, I want to generate an index image for this website or for this project, finally I get this image. So I guess you know why, right? Because our presidency, we have lots of the photo about our presidency on the internet. And throughout the big data, throughout the large language model, so such kind of information, such kind of data is dominant in our data set. So that's why when we put someone, even his face, he doesn't look like President C, they will try to style transfer into something that is related to our big data. So this situation happens, and the index page, he just like our President C. This kind of problem happens not only in the AIGC, not only in the image generation, it also happens in our large language model. So when you ask something, so most likely the information is related to the large data set, large language model, the big data set. So honestly, some of our wording is missing in our large language model, especially about the elderly. So in this project, we have two goals. The first goal is let the teenager or let our university student know that the large language model, they are not cover all the information or all the feelings of all the peoples. So they have to aware that some of the information, some of the voice is missing in our large language model. And other things we want we want to achieve is, yeah, the elderly, when we go outside and do the research, they really care about their story. So they one of the things they really afraid is they will die. Another thing they will afraid is they think that they will seems like do not exist in the world when they pass away. For example, when they pass away, some of the elderly, they do not have child, they do not have even their child maybe 60 something, they do not have their next generations, and then they do not have loss of the fans when they pass away, maybe 1 or 2 years at most, 5 years. So I would say all their story, all their wording does not exist in our internet, in our situation. So that is the project we want our teenager understand, and then we want to keep the memory of the elderly into a digital human form so that they understand someone care them, and then some of their information can still be here after they pass away. So yeah, I speak quite a lot of things. So let's have a look with the videos. It's only 2 minutes. It's easy to understand the whole situations. So let me play the video. Hey, is working?
No,
No.
no, it's
Yeah,
maybe.
No, it's not waiting. But honestly, yeah, you can scan this QR code and then have a look with this video perhaps later on, and then I will try to post this video on the web. I'm not sure that why you cannot pay, maybe because I'm in China right now and this video is on YouTube. So if you are in PolyU, perhaps you can play these videos. So it try to give you some basic understanding about our project, but it's okay. Hey, it's working? No. Then we just forget.
Just black screen.
Okay, this is okay. We just forget about it. So as I have mentioned before, so honestly, today when we are teaching ethics or when we are teaching the mental health or such kind of the things to our university students, we think, yeah, we face lots of the challenge. The main challenge is lots of our students, they are not motivated in teaching this kind of ethics, this kind of mental health, this kind of healthy wellness. So honestly, they just doesn't care. So when maybe 5 or 10 years ago, when we prepared similar course, we'll prepare the essay, we'll prepare the case study, we'll deliver the information to them, and then they will think, why the essays? But nowadays, they just put into open AI. So for them to better understanding what is mental health, and then for them to understand what is the effect, it's good that to put them to interact with the other. So in our surface learning project or in our community project, we put our university student with the elderly to understand the needs of the elderly, and then it also provide a intergeneration storytelling. So it's a real memory, and then it's a good digital computer science forms a good digital tools to bridge these two group of the people together. And it also recover the missing voice in the LLM. So that is our goal. So from the basic understanding of our course is a surface learning model with the 5E. So the 5E model is a constructive teaching. So it care about the explore, to let the student to explore the needs and then explore the world, the real needs of the world. And then we have to explain, match to our academic knowledge. For example, if they can explore, sell something, or there is a problem, there is a missing thing in our missing world, we have to explain what is the technologies that is ready for us to fit this hole, or our technologies, maybe we can do something to improve the situations. Then, after we explain, they have to elaborate and then try to use this kind of technology to solve the missing problem or to solve this kind of the situations in our real world. After that, for the 5E model, then we have to engage with the survey receiver. So in our project, we engage with the elderly, because without engage, they never know what is the new real needs of the clients, and then how their technologies can solve their real needs or real problem in our world. After that, the teacher will have to evaluate, and then also the survey receiver will have to evaluate their work and then make sure that they understand the whole situations. Finally, this situation repeat, and repeat. So this is a main concept of 5E model of our teaching and of constructive teaching, and it's also a core concept of service learning. So this is the theoretical part, but honestly, when we go to the theory, so here is our situation. Our student will co-create the project with the elderly. So in our project, we will use the new technologies, and then we'll create digital human then this kind of products can be explored in the mobile platform, can be explored in the VR platform, so that they can put it to the public and then demonstrate to the public to let more and more people understand the needs of the elderly. And that is how the digital device together and digital device can be bridged, and together with how to build the empathy for the public. Of course, we also prepare lots of the ethical cards, lots of the cards exercise that can help the teenager, our student, together with the public to understand what is the meaning of the ethics. And there is the situation that we held and then hold our, I would say that change our computer science class into this kind of settings and help the problem of the world. When we go deep into the course settings and what we have done, so you can divide into 1, 2, 3 parts. We have our student, we have our elderly as a social receiver, and then the most important thing is we build our platform to facilitate the communication between the student and the elderly. So the student, before they go to meet the elderly, so they have to understand all the things about the mental health, healthy lifestyle, all the things about the digital empathy, device, and all the things about the empathy. Then they also need to learn something that is related to computer technologies. So they learn how to use the 3D construction, they learn how to build the 3D world. So they capture the situation, and then they rebuild the 3D scenes, and then show these 3D scenes to the elderly. So once they show these 3D scenes to the elderly, we will say that, hey, now you know that our student come is not only show the case for you, we are come for we co-create to rebuild your story together. So somehow to let the elderly understand or experience in this kind of 3D demos, so they understand the power and understand our objective. Our student will interview with the elderly. So they will, for every elderly exam, remember, they spend at least 30 minutes to interview them and then record down their story, capture their image, and then turn their story into task, and then somehow turn them into the digital human. So we collect the story from the elderly, and then we create a digital human. This kind of digital human further will be put it into different forms, formats. So they may be put in the web, they will put in the VR device, VR, LBE, that is a real big showcase, or something that is really exciting. For example, here we have the LED interactive installation to showcase all our situation to make or attract the public eyes. So the platform here try to facilitate all this kind of the resources management. They facilitate the asset management, they facilitate the virtual space management to help our student and the elderly to connect. Excuse. Sorry. Just a minute.
Oh,
yeah.
Thank you.
Yeah, here, I'm sorry, I just want to tap text skip. Okay, so that is our situation. And then, yeah, so our platform, see that? So we will try to facilitate a really interesting tools for our student to reconstruct all the 3D models. So at that time, our students just use their mobile phone, iPhone or smartphone, Android phone, to use their camera to capture the 3D scene. After they have captured the 3D scenes, then they can put this kind of the 3D scenes into our web platforms or VR platform and show the elderly. So if you are interested, you can scan this one. So we can combine the story with the elderly by using the techniques of the LLM and also the RAG technologies we'll discuss later, and then turn the story of the human into of the elderly into a digital human. So in here, we try to use at least four kinds of technologies. The first one is a 3D reconstruction, 3DGS. Another one is the WebXR. The WebXR helps us to put all the information, 3D environments, and also digital human on the mobile phones, on the VR device, and all different kinds of the platforms. We also using the LM, large language model, together with the RAG, retrieved augmented generator. So somehow we try to collect the story of the elderly. What we have done is somehow we try to combine different kind of technologies and then help the elderly to understand that someone still care about them. So we use the 3DGS to reconstruct the 3D environment that we have captured from their living space, and then this kind of environment is somehow their living space, so they know that their living space can be reconstructed through our applications. And with the WebXR platform, so their applications can be able to change it into somehow here, let all the mobile phone, let their I would say the next generations or let their children to still can talk or interact with them throughout this kind of web platform. Whatever they have installed, they want to install in the iPhone or they want to install in the Android phone, all the thing is ready, and you can travel through our virtual platform in this kind of settings. So we also combine the LLM and then RAG technologies. LLM is large language model. So somehow we combine the large language model connect with the DeepSeek. So the DeepSeek, they provide a good, I would say that presentation layer for them to discuss, to talk with the audience. But somehow we need to collect their story. So we have using the RAG technologies, retrieved augmented generation. So somehow we collect the elderly story and then change to 5,000 to 3,000 to 5,000 wordings, and also connect with their personality, talking about their real or most interesting story in their life, combined with the LLM. Ask the LM to reconstruct the digital humans, and then they act like the elderly. Last but not least, so we use the AI lip sync. So somehow we also capture the image of the elderly and then their photos, because somehow here, digital human, when we are using the 3D, we still have a lot of the problem in synchronize their facial expression. But for the 2D, it's pretty good. So we are using the 2D lip sync algorithm to synchronize the voice of their faces. So somehow when they are producing the interactions with their target audience, all the things will become more and more natural. So the outcome of this project can be turned into two parts. The first one is the impact on the student growth. Honestly, the impact of the student growth is really good. For the traditional class that we have using to teach the ethics and also teach the mental health, etc., we only get 4 out of 5 SFQ. But when we are using this kind of approach, connect our university student with the elderly, and then they co-create the product together, the SFQ, we jump to a 4.6. We haven't experienced this kind of big jump in our surface learning class and also in my computer science class. So this is one of the things that is really important. And then for the questionnaire, we find that we can improve quite a lot about their, especially about their empathy and caring and social responsibility, because when they really touch the elderly, they know that something is missing from our technology, something is missing from our current world. So somehow, as a university student, I have the responsibility to fulfill this gap. Perhaps we use the technologies, so they also improve the problem-solving skill. Perhaps they use the other social skill, but they know that we have the responsibility to solve this kind of questions. And also, we receive quite a lot of good comment from our students. Most of them, they never think that technologies can be used like this kind of settings. They can capture the human memory, they can capture the needs of the human and then transform them into another form and let the others know that the story still be here when they are not when they are passed away. Talking about the elderly, so we also use the questionnaire to measure the improvement of the elderly. So somehow we are using the QL, Quality of Life EQ 5T5L questionnaire framework, and then there are 5 dimensions. Of course, this kind of app, we cannot improve all the dimensions. For example, self-care, for example, the mobility. The elderly, when they have the disability, the elderly, when they are maybe bounded by their money, so they cannot easily to go somewhere else. But somehow with this kind of the applications, they know that their story can be can be stay here for a very long time, or can be transformed into a digital form, their depressions, anxiety improve a lot. From our data, so they improve more than 12%, 12.5%. And then for the p-value, that is really significant. The elderly, we think that we do something, therapists do something to help them to improve their quality of life, to improve their needs. We find a small, I would say that a small missing points about their life, and then that's something we can do for their own interest. So yeah, that is our platform pedagogy innovations, and then this is our technologies comparisons, our SWOT and also things. So perhaps I will turn it into the Q&A time, because maybe my network is not really good. And then here we have a small demo. This one, we have a small demo about our work. So if you are interested, you can just use the QR codes to scan this small demos, and then we can, at the meantime, we can use the remaining time to start the Q&A sessions.
Okay. President, give me a minute. Passing mic to the student here on site.
Thank you so much.
Hello, Professor. I have 2 questions. So the first one, can you hear me?
Yes.
Okay.
It's good.
Yeah.
I'm sorry.
Thanks. For the first one, I've seen the sample video of doing this kind of storytelling with elderly in mainland China. Have you used this technology for elderly in Hong Kong? And do you have, if not, do you have plans? So the second question is, these elderly speaks the dialects, 方言. Have you faced any challenges to use the LLM models? And I'm thinking, like Cantonese, is it possible to do that as well?
So you have 3 questions. The first question, let me answer first. For we have using this case in Yunnan for the elderly, and honestly, we have also used this case in SAGE, K Phúc Hội, K Hong Hội. So we have also let the Hong Kong elderly to try this kind of statics, and yeah, we think that is a great idea to do this kind of thing, because somehow they can have some story to send, or even they haven't passed away, they really excite and then send this kind of the interaction to their son, to their daughter, and then show that, hey, this is the most interesting story that is about our life. So that is the first one. Second question is about the 方言, right? So yeah, I speak in Chinese. I'm sorry. 科大讯飞，科大讯飞。其实在中国有一个比较好的技術，在廣東話喺中國有一間公司叫科大訊飛。There is a company in China, so that is handle lots of this kind of I would say the local language in China. Honestly, whatever you are saying, say that you are speaking some local language in Yunnan or some local language in Hong Kong. So their technologies can change the speed to text in, I would say that 80 to 90% of the coroners. So that's why our university students need to be here, because some of the speed to text, they are not really quite make sense. So our university students still have to improve this kind of the studying. In Hong Kong, so there are couples of the technologies way to do the speed to text. So if you are going to use Microsoft Asia, so there is a Whisper tools that you can change that. The P is a PAS, is a platform as a service. So this is a AI algorithm from the Microsoft. It can change the, I would say that Hong Kong style English. That means we combine the Chinese and then we combine the English together, and then they do very well. So I would say that 98, or exactly remember, it should be 98 or 97% of this kind of Hong Kong style Cantonese, they can still prepare and then work very well. Because the most important thing of this kind of setting is not only about understand the English and understand the Chinese Cantonese. It's about understand the context of your situation. So could we match the correct wording to your task. So that is the challenge. Hopes that I haven't, yeah, I have answered all your questions. Did I miss one of them?
Yeah, there's a lot of questions.
Thank you very much. So my follow-up question is about the Hong Kong 期康會 elderly. Is the
SAP.
video published somewhere online? Can you provide that? If not, I have no idea how a story is presented, because in your students' video, I just saw some scenes in rural China, and I didn't know whether an elder is just talking his or her life story and showing his or home environment, something like that. Is there a sample video that you can provide to us?
I see.
Thank you.
So can you remember this link? Give me 2 more months. I need time to process. And honestly, this kind of application, we are still finding someone to sponsor about server, because the computation power to rebuild a scene is around 10 Hong Kong dollars. And then to keep the digital human for each month is around 7,000 Hong Kong dollars. So we are finding a server, and yeah, we have this kind of settings, and then it's possible to do it. And honestly, for the elderly, they tried and then they send it through our platform. So yeah, we are still looking for some donation to do it. But give me 2 months. Remember this link here. There is a QR code. Remember our platform. So around I would say 2 months. So all the things will be ready.
Okay, Professor, there's a question from online. Can you click the Q&A icon so you can read the question?
Right.
In
the VDGS, when applied into mental health, is better for the psychology impact or any evidence in being mental, in healing the mental health. Okay, VGS, I will say video construction. So video construction can help the mental health, right? So it can help in a couple of ways, because not only about the video constructions, we are talking about the virtual environment, immersive environment. So immersive environment have been proved that they can help a lot in mindfulness training. So this kind of mindfulness trainings, I would say that around 3 or 5 years ago. So there are lots of applications. There are lots of the paper prove that immersive VR mindfulness training works. And at that time, we only allow the user to go to some abstract or go to some pre-record videos or something that is not related to their personal life. But right now, with the video scanning, if you are just using your iPhone or if you are just using your smartphone to do scanning, you can create your own virtual space. You can create your own immersive environments for mental health training or for different kinds of, I would say that therapy. So I would say that it can help, but it needs time to prepare the paper, because, for example, the VGX algorithm is only around 1 or 2 years ago. So after we have created this platform, so yeah, I would say that this kind of WebXR VDGS platform, we are the first one to create into it. So it takes time to let the other people know we have this kind of tools, and then let the others know that this kind of tools can be applied into different applications. It takes time.
Is there any other question from the class, from people in the classroom? Okay, thanks, Professor. It seems like there are no more questions from the class.
I see. I would like to say I'm really sorry about my network situation. So yeah, and then thanks for your time. Thanks a lot.
Okay, thank you, Professor.
Thank you. Bye bye.